Very good evening to everyone, and I'll be anchoring the session, as ma'am said. So the topic is masterclass in pediatric joint pains, and we have very two eminent speakers for today's this discussion. I would like to welcome Dr. Sagar Bhattad and introduce him. He is the first DM in the field of pediatric immunology and rheumatology in India. And he has also done his fellowship in bone marrow transplant and is also certified by the European Society for the same. He's a lead consultant in the Department of Pediatric Immunology, Rheumatology and Bone Marrow Transplant at Manipal Hospital, Yelahanka, Bangalore. He is a great academician and has many publications and chapters to his credit. He is also the recipient of the Major General Amirchand Gold Medal for Research in Pediatric Lupus, and he has done several bone marrow transplants for PID patients and diagnosed almost more than 550 plus patients with primary immunodeficiencies. I welcome you, Dr. Sagar Bhattad, to this program. And the next speaker would be Dr. Archan Sil, who is actually, he's also a DM in pediatric clinical immunology and rheumatology, and he's the assistant professor and in charge of this department at Burdwan Medical College. He's also visiting consultant at Daysun Hospital, Calcutta. He's a fellow in Press Emerge from Italy as well, and he has various publications and again various posts he has held in societies for rheumatology and immunology. And Dr. Archan Sil also has numerous publications, and he has also won the youngest this one investigator award in 2023 in the Press Yim. And he has also got the best oral paper awards in multiple conferences, and also the grant ICMR grant for this thesis in 2021. So with these few words, I would like to welcome even Dr. Archan Sil to this program, and we are all very eagerly waiting to hear from you both. Over to you, Dr. Sagar and Dr. Archan.
Good evening. Am I audible?
Yes.
Yes.
My screen is visible?
Yes, Sagar. Visible.
Good evening, one and all. Thank you, Ravishankara sir, Sumita ma'am, and everyone for this opportunity. As has been highlighted right for the last 15 minutes, that joint pain is a very, very common symptom that we as pediatricians deal in our OPD. And the purpose of this session is basically to highlight few very common cases that we see in practice and give an approach as to how, as a pediatrician, we can all approach children who present to us with joint pain. So the objectives are present common cases that present with joint pain and provide a broad approach to a and literature says at least 30% of school-going children would complain of pain in legs sometimes during their school life. And the cause could be a benign disease, and sometimes it could be a serious condition. The first thing I would like to highlight is that whenever a pediatrician, as a pediatrician, we see
Sagar's voice is breaking.
Sagar, your voice is breaking in between. I think you can put your video off and you can speak. You can put your video off, Sagar. I think that will save the data. Wait.
Okay.
Yeah.
Is it better now?
Yeah, better now. We can hear you. You can continue now. Yeah. No, your voice is not heard. Sagar, your voice is not heard.
With pain or heat, warmth overlying the joint, one can think of arthritis. So this is a very crucial difference because our approach will completely change if it is arthralgia versus arthritis. These are some common warning signs in every child. When a child presents with joint pain, we must ask for
Dr. Sagar, your voice is not heard.
case, followed by Dr. Archan, and then we'll go back to the
Your voice is breaking. Your voice is not heard.
I think we can ask Archant to present, and meanwhile Sagar can adjust his data. Speed.
Dr. Sagar?
Yes,
Sagar,
ma'am.
your
Dr.
voice
Sagar?
is not at all heard anything. Only the slides are visible. I think there is a problem in your there's a data thing connection. Can you adjust it and can later? Can we ask Archant to present his case?
I have changed my internet connection. Is it better, or Dr. Archan will present?
No,
Yeah, it's
in
better
between
now.
now it is heard. Now it is heard.
Yeah, I have just changed my internet connection, sir.
Yeah. Okay. Fine.
Okay. So a 5-year-old girl who presented with pain in legs for the past 3 months visited a pediatrician. Vitamin D levels were checked. Vitamin D was low, and this child was prescribed vitamin D weekly for the next 5 weeks along with calcium supplements. She continued to have symptoms. Then the child or the family visited another pediatrician. This history was revisited, and the pediatrician thought, could this be growing pains? But there was something striking. There was limp. The child was actually limping while walking into his OPD, and there was a change in the gait. The mother classically said that the child is worse in the morning but gets better by the evening. The girl would actually refuse to walk in the morning hours and would actually appear near normal in the evening. So this was a very characteristic symptom brought out by the family. There was no history of any trauma, no fever, no rash, no bleeding tendency. Otherwise, the child was pretty active and playful. Now, that is very important to note that the child was active and playful. Past history was not contributory. Family history was again not significant. There was no contact with a positive case of tuberculosis, no history of any autoimmune disease in the family. Developmentally, this child was normal and immunized for age. And on examination, the weight and height were preserved. The child was again active and playful. There was no pillar, no lymphadenopathy, no organomegaly. And the only positive finding on MSK examination, musculoskeletal examination, was the left knee swelling where the patellar tap was positive. And as you can see from the clinical picture, clearly the left knee is swollen, the right knee looks normal, and this child would actually walk into the OPD with a limp but appeared playful and active. This child was in fact referred to the orthopedician who suspected septic arthritis because this was a single joint that was affected. An ultrasound knee was performed which showed synovial thickening and effusion. An X-ray was performed. However, there was no fracture or evidence of osteomyelitis. The orthopedician thought again, did not appear like septic arthritis, and finally the child was referred to a pediatric rheumatologist. On review of history and examination, this is a 5-year-old girl who is limping for the past 3 months. There is early morning worsening, meaning to say morning stiffness. Often in children, it is very difficult to elicit the history of morning stiffness. Parents would say that the child does not walk in the morning. There was no fever, and the only positive finding was left knee arthritis. So with this finding, this is actually a very straightforward diagnosis of oligoarticular juvenile idiopathic arthritis. The investigations, as you can see, the hemogram appears near normal. The ESR was 20, CRP was negative. ANA test, which was performed by immunofluorescence, was 2+, it was positive. And the eye examination, which was performed, ruled out uveitis. It is very essential to look at the eye in a child who presents with arthritis. Treatment, a course of naproxen, there was partial relief. Intra-articular steroids were given, and there was complete resolution of arthritis. This child is now under regular follow-up, and we have advised 3-monthly eye checkup. Juvenile idiopathic arthritis is an autoimmune disorder. It is characterized by morning stiffness and joint swelling. This must be treated by a pediatric rheumatologist, and these patients require long-term follow-up. And the subtype of GIA that I spoke about is called oligoarticular GIA. Often 4 or less than 4 joints are affected, but what is important is the age group. This disease classically affects preschool children, more commonly seen in girls. Knee joint is the most commonly affected joint. Sometimes ankles can be affected. If ANA is positive, these children are at much higher risk of developing uveitis. So this is not growing pain when joints are swollen, when there is a change in the gait, when there are night pains, when there is fever or rashes or bleeding tendency or loss of appetite or weight loss. With this, I would like to just thank for all of you for giving this opportunity. Just want to highlight that our team right now is at Manipal Hospital, Yelahanka, and I also want to take this opportunity to invite you all to a Manipal Immunotransplant Summit, a conference that we are organizing very much in Bangalore in April 25-26, discussing variety of immunodeficiencies, where Surjit Singh sir, Deepti ma'am, all will be present in Bangalore. Thank you. Thank you.
Deepti ma'am, would you like to give your expert comments?
At the outset, I must thank IAP Karnataka, Dr. Ravishankar, Dr. Kushal, Dr. Sumita, all the dignitaries from various specialities for giving me this opportunity. Thank you, Sagar, for presenting such an important case and for bringing out a very important message about uveitis in JIA. Now, if I have to analyze Sagar's case, the first thing that Sagar said, which was very important, is to differentiate between arthritis and arthralgia. And clearly, this child had visible swelling and hence was having arthritis, which was monoarticular. Now, when we look at arthritis, we go step by step. The first step is to differentiate between arthritis and arthralgia. And after arthralgia, you would go, after you've confirmed it's arthritis, then the few important things is the duration and the number of joints. Now, in Sagar's case, probably it was 3 months. That means it was a chronic. Anything beyond 6 weeks is classified as JIA. Less than 6 weeks is acute arthritis, and beyond 6 weeks is you go into the pattern of JIA. The patterns are important. Here it was a 5-year-old girl, and which Sagar really specifically told you is the fact that the child was well, she had minimal limp. There were no systemic features. Now, this is a child, a young girl, monoarticular or oligoarticular disease going on for 3 months with morning stiffness. The most important thing here is to look into the eyes. The most relevant test here, which Sagar pointed out, was anti-nuclear antibody test. This anti-nuclear antibody test positivity is not lupus. This is ANA positivity associated with JIA. And in this particular child, even if there is only arthritis to begin with, the most important thing that is to be taken care of is the eyes. Development of uveitis may not be there initially, but serial follow-up of these patients is important. So simple things which one can learn from this case is everything is not growing pains. Importance of morning stiffness is important. Recognizing the pattern, a young girl with monoarticular disease or oligoarticular disease without systemic signs, without much of ESR-CRP elevation, it is important that we pay attention to the joint as well as we look at the eyes. So our uveitis here will always take precedence over management of arthritis. Arthritis is easier to treat. Uveitis can become chronic. And as rightly pointed out, initial management would be simple NSAIDs. Some children would require intraarticular injections, and some children, especially more for patients who develop uveitis, would require DMARDs like methotrexate or adalimumab. So referral with morning stiffness to a rheumatologist and doing appropriate test is the crux of this case.
Thank you, ma'am, for your expert comments. Shall we move on to the next presentation, Sumita, ma'am?
Please, Archan.
Yes. Yes. So, Dr. Archan Sil, I invite you to present your case.
Yes. Am I audible?
Yes, you are.
Yes, yes, sir.
And my slides are visible?
Yes, visible.
So good evening all. It's my pleasure to speak on this platform. At the onset, I'd like to thank Sumita ma'am, Ravishankar sir for inviting me to speak, and thank you IIP Karnataka. So today's topic is joint pain. So there is no conflict of interest to disclose. Definition of arthritis has already been highlighted by Dr. Sagar Bhattar. So either swelling or any two of the following three: limitation of joint movement, pain on movement, or heat or warmth of the underlying joint. So I will straightway go to the case 1. So here also, 6-year-old boy with a fever for almost 1 month duration and right knee swelling for 2 weeks. But unlike previous case, here the child is not that active or playful. Here the child is irritable. And outside, considering the diagnosis of septic arthritis, the child was treated with IV antimicrobials and steroid was also given. So examination showed the child was sick looking and general examination revealed paleness. So here also only single joint was involved. As you can appreciate, right knee was swollen, it was painful, it was tender, and restriction of movement was present. But systemic examination revealed splenomegaly in this case. So with this background, when we went ahead, what are the possibilities that should be considered? Infective causes like septic arthritis, tuberculosis would come under consideration because of bone articular involvement. Brucellosis, Lyme disease, HIV, and infective endocarditis are other possibilities, other infective possibilities. If we disregard fever, some non-inflammatory causes like hemophilia, trauma can also be possibilities. Rheumatological disorders like acute rheumatic fever, although it's a very initial phase, only single joint involved, so acute rheumatic fever is unlikely. But other rheumatological diseases like JIA, as already mentioned, oligoarticular JIA, and other connective tissue diseases like SLE should also be kept under consideration. Last but not the least, malignancies like acute leukemia and neuroblastoma can also be the possibility. When baseline investigations were done in this child, look at the complete hemogram, complete blood count. Hemoglobin was very low, severe anemia was present. Not only anemia, leukocyte count was also depleted. And look at the differential count, it was lymphocytic predominance. Platelet was also on the lower side. However, peripheral blood smear didn't show any atypical cell or blasts. But with this history, brief examination, and initial investigations, when we went back and on further inquiry, two important points came out. One from history. On further inquiry, it was revealed that there was night crying present for last 2 weeks. And on detailed examination, bony tenderness was elicited. So when we went ahead with the investigations, ESR and CRP were elevated, so as uric acid and LDH. However, tuberculin skin test was negative, and when ultrasound of the affected joint was done, it showed periarticular swelling, which was more significant as compared to the synovial hypertrophy and effusion. So ultimately, bone marrow examination was done, which showed plenty of blast cells. Final diagnosis was acute leukemia, which presented with arthritis. So this is an atypical presentation of leukemia, which is not very uncommon. So if we retrospectively analyze the case, what were the soft pointers towards this diagnosis? From clinical point of view, nighttime pain, nighttime crying was important. On examination, bony tenderness was present. So periarticular tenderness, bony tenderness, this was important. Systemic examination showed splenomegaly, and investigation showed cytopenia with raised LDH and uric acid. So these are the clues, these were the red flag signs which pointed towards the underlying sinister diagnosis. This was an important publication from PGI Chandigarh, which analyzed the arthritic presentation of acute leukemia in children. They analyzed 11 children who had this arthritic presentation, and they found that history of night pain, non-articular bony pain, presence of joint pain out of proportion to physical findings, anemia, leukopenia with lymphocytic predominance, and thrombocytopenia. All these parameters were significantly associated with the diagnosis of acute leukemia in a child who initially presented with arthritis. So when to suspect leukemia in a child with arthritis? In nutshell, when the pain is not exactly located at the joint, periarticular pain is important, bone pain is important, and pain is disproportionate. Nighttime pain is also important. On complete blood count evaluation, cytopenias or abnormal blood counts, poor response or worsening with steroids or non-steroidal anti-inflammatory drugs. And last but not the least, systemic features like fever, predominant fever, weight loss, appetite loss, and hepatosplenomegaly or lymphadenopathy. To conclude, several children are referred to rheumatology clinic with musculoskeletal pain, but hematological malignancy should be excluded in presence of subtle laboratory and clinical features, as I have already elaborated. So early steroid use can mask those signs and delay the diagnosis. So steroid use is essential in management of juvenile idiopathic arthritis, but starting steroid is never an emergency. Thank you.
Thank you, Dr. Archil. That is a very important message given by you to all the pediatricians. I invite Dr. Deepti ma'am again for her comments.
Thank you, Archon, for bringing out this important case. And I think the message is quite clear that patients with acute lymphoblastic leukemia or acute leukemias can come with primary joint symptoms. And we should be aware of the fact that acute leukemia can present with joint and limb pains. Now, having said that, I think there are few things that as a pediatrician you must be aware of. And the first thing is differentiating between morning stiffness and night pains. Children with night cries the mothers will probably tell you that my child doesn't sleep well at night. He will get up because of pain. If a child is getting up with pain at night, it is a red flag sign. Night cries are important. While on the other hand, if we compare with what Sagar showed, it was a morning stiffness. The child slept comfortably, gets up in the morning and has a limp. There is a difference between these two symptoms. Acute leukemia, when you think of acute leukemia, you also have to be aware of the fact that apart from night cries, the child can have fever, they can have splenomegaly, they can have lymphadenopathy, as well as sometimes you may be able to elicit a sternal tenderness. These examination findings are equally important. Fever is a very important sign. Many patients with JIA, except for systemic JIA, because systemic JIA will always be a close differential to acute leukemia. Even though if on CBC you find severe anemia, lymphocytic predominance, and not polymorphonuclear response. In systemic JIA, you get polymorphonuclear response. Polymorphs are more, while in a lymphoblastic leukemia, it is the lymphocytic dominance. One has to recognize this lymphocytic dominance. It may be, the complete blood count sometimes may be absolutely normal. Thrombocytosis is seen in a JIA, while thrombocytopenia or sometimes near normal counts. If platelets are not rising commensurate to the inflammation or the duration of inflammation, that also should be a red flag sign for you. So interpret your CBCs correctly. Severe anemia, hemoglobin was 5 in this particular case. JIA, hemoglobin falls, but not to extent of severe anemia. It may fall to 8, 9, but 5 and 6 definitely is a red flag. And always never be in a hurry to start corticosteroids. The moment you start corticosteroids, you've actually masked everything for a very long time. So as a pediatrician, take time, call the child again, do another test, see the trends if the platelets are falling. A very close differential at this point of time remains systemic JIA with macrophage activation syndrome. Because again in mass, you have similar kind of faults and it's an urgency to start steroids. But looking at the sickness, probably you'll have to see, decide on the two, refer, do a early bone marrow. You will always get the clue. Two things from both the cases before I end up is refrain from making a diagnosis of growing pains. Growing pains are very subtle, not very troublesome to the child. And refrain from referring to an orthopedician, especially in the first case. Refer to a pediatric rheumatologist if you need help. See the patient yourselves. Referring to orthopedicians is not required. And also, whenever dealing with a joint pain child, do not do x-rays very often. These are some messages that I wanted to give. And thank you, Sagar and Archon, for bringing out two very important topics, two very important cases, which I think all of us during our career would have encountered. Thank you.
Yeah, very nice case, madam. Very nice discussion from you. Really, a lot of points we got known about the things. And Sagar and Chen, really fantastic cases. Meanwhile, let me acknowledge the presence of Dr. Kashi sir, and Dr. Sudhakar TN, Dr. Amal Raj, Dr. Nagesh, Kishore Baindur, Nandakumar, Raj Katke from Aurangabad. Thank you for joining. And Archan Sinchana for next case.
Yes, sir. And also many thanks to Dr.
If
Kalpana Datta, Madam,
if I
Dr.
may
Nandakumar,
just
sir. Yes.
if I may just step in for a minute,
Yeah, please,
both
sir. Please, sir.
both these cases were highly illustrative and in sharp contrast with each other. On the one hand, Sagar showed a 5-year-old happy-looking girl, while Archan showed a 6-year-old sick-looking boy. So the crucial issue here is that rheumatology is one branch that does not require some major investigations. It's 90% of it is dependent on history and physical examination only. And most often, the answer lies in the file which the patient brings to you with whatever errors have been committed or omitted in the past. I completely agreed with Dipti's comment that there is no urgency to start steroids. The orthopedic surgeons, unfortunately, are the root to pediatric rheumatology, and it still suggests that we are a branch who have to sell our specialty before selling ourselves. There are two other small clinical points I wish to bring out. Oligoarticular arthritis never involves the hip. So if you see a hip joint involvement, be very cautious. Second point is that if you have a unilateral nocturnal leg pain, which wakes the child up, but otherwise the child looks good, there are no systemic features, please suspect an osteoid osteoma. It is very easily correctable. And last but not the least, from my experience over the last 2 years, if you see a child with autism who walks into your office, or sorry, who's referred to you because of extreme irritability and joint pains, please strongly consider scurvy. We have seen 5 children in the last 2 years. And last but not the least, these x-rays which may have been taken for Dr. Archan's case, if you look at the metaphyseal ends of the long bones, they are strongly likely to show lucent lines which are quite typical of leukemia. Thank you.
Thank you, sir, for those very important messages for us. And I also acknowledge the presence of Dr. Nandakumar, sir, President of Kerala State Branch, and Dr. Gopi Mohan, the Secretary of Kerala State Branch, and many other seniors and teachers, Dr. Sudhakar D from Chennai, Dr. Nandini Kumaran from Coimbatore. Thank you, everyone, for joining in. And now I would like to invite Dr. Sagar Bhattad again for the next case.
Just a minute, sorry. Give me 1 second. Is my screen visible?
Yes.
Yes.
I'm just opening up the second case. Okay, yeah. So quickly coming up to the second case, again, that would present predominantly with joint pain, but would end up with a very different diagnosis, but something that we again see in our practice very commonly. Yeah. So this is a 6-year-old boy who presented with pain in legs again for the past 1 week, but then for the past 2 days, I mean to say somewhere around day 5, day 6 of illness, the child started having swelling of the ankles and started limping. And the family also reported pain abdomen for the past 1 week. A detailed review of clinical history, apparently well 1 week back, reported pain in the knees and ankles, treated with calcium supplements. By day 5 of illness, the child in fact developed swelling of the ankles and started limping and was given ibuprofen. And over the next 2 days, in fact, the swelling got better. Pain abdomen was intermittent, present for the past 1 week, colicky in nature. There was no loose stools or blood in stools, no vomiting. And the pediatrician, because of this intermittent pain abdomen, got an ultrasound abdomen, which was said to be normal. And this child was offered symptomatic treatment. By day 7 of illness, something different happened. This child now developed painful swelling over dorsum of hands, as you can see from the clinical picture. This swelling was painful and was tender to touch. By day 9 of illness, now this child started having some rashes over the legs. Initially, these rashes were seen only over the legs that gradually progressed to involve the buttocks. No fever, no hematuria, no oral ulcers, no rash over the face. Past history was absolutely not contributory. Family history, this was the only child and nothing significant on family background. On examination, this child had a weight of 18 kg, height of 160 centimeters, blood pressure was normal. And as you can see from the picture, I'm sure each one of you will make this diagnosis. There were these petechial purpuric rashes palpable over both the lower limbs. However, ankle swelling was not to be seen at this point of time. I'm sure all of us will make this diagnosis. This is nothing but HSP, henoch-schönlein purpura, the new name being IgA vasculitis. I'll just bring out 3 or 4 salient points before I end. Subcutaneous edema over the dorso of the hands and feet and around the eyes, forehead, scalp, and scrotum may occur early in the disease, particularly in the very young child, says our textbook. 14 to 36% of these cases can present only with abdominal pain even before the rash starts, and that can be a nightmare to diagnose HSP in that setting when these children present with isolated pain abdomen, and only when the rash starts we become confident about the diagnosis. So almost 1/3 of the cases, abdominal pain can be the prominent or the presenting manifestation. And finally, a word on arthritis. Almost 50 to 80% of these children do develop arthritis. This arthritis typically affects large joints, the knees and ankles. If you closely examine, it is more of a periarticular swelling rather than joint swelling. The pain is very severe. The child would often limp. But then this is transient, this is non-erosive, and very much responsive to NSAIDs. And that is why often when you follow up these children, the child who is limping a couple of days back would start walking. And that is the response to NSAIDs that you often see in a patient with IgA vasculitis or HSP. I just will leave this slide so that all pediatricians document and block your dates for April 25 and 26. Once again, thank you for the opportunity. Over to Sir for his valuable comments.
May I invite Kupchandani sir for his comments?
Sir is muted. Sir is speaking, but he's muted.
Yeah.
Yeah, okay. So, Sagar, I was just hoping that your next case would be an IgA vasculitis, because this is something that is really commonly seen in practice. And invariably, you would have noticed in your practice that many of these patients come in crops. Suddenly, at some time of the year, you will see one, and then you will see the next 5 in the next month or so. It is something that can be definitely managed at the pediatrician's level. And I entirely agree with you that the rash could be late in coming, because this has very often led to misadventures. I recall a child with a blistering penile gangrene, which preceded the rash, and a child with intussusception, which preceded the rash. So these are important points, and very often there have been surgical misadventures where the child has been taken to the OT without anyone's fault. But the in tongue-in-cheek, I would say, at least raise the child's pajamas before you take him to the OT if you see intussusception in an unusual age group. Epididymo or cultis is another surgical manifestation. And the most important message I would like to convey is that these patients, even if they have been managed at the primary care level, require a urine examination every 15 days to 3 weeks, ideally for at least 6 months, because hematuria may be the only manifestation of the nephritis and may come up later. So this is what I have to state. We could possibly move to the next case.
Thank you, sir. I invite Dr. Archan. Yes.
Yes, sir.
For the next case.
So is my slide visible?
Yes.
Yes.
Okay, okay, sir. So moving ahead to the case number 2. So here 9-year 11-month-old girl from Jamtara, Jharkhand, presented with complaints of fever for 3 months, last 3 months, and joint pain for 1 month. Going a little bit deep into the history, the fever was intermittent, low grade, 2 spikes per day, and used to subside with antipyretic medications. Joint pain, which was present for last 1 month, was insidious in onset, gradually progressive, non-migratory, and it was symmetric involvement involving both large and small joints, bilateral knee, ankle, and small metacarpophalangeal joints and proximal interphalangeal joints of hands were involved. And morning stiffness was present, which lasted for more than an hour. So this is the examination showing swelling of bilateral knee and ankle, and the small joints of hands, that is metacarpophalangeal joints and proximal interphalangeal joints, mainly had tenderness and restriction of movement without prominent swelling. Systemic examination showed hepatosplenomegaly. Spleen was just palpable 1 centimeter below the left costal margin, and liver was 2 centimeter palpable. So with this, the same possibilities, infective causes, inflammatory causes, and non-inflammatory causes. But with this duration of fever for 3 months, joint pain for 1 month, some of the causes will go out and rest will remain. Now, coming to baseline investigations, like my previous case, this case is also showing pancytopenia. Hemoglobin was 7. Platelet count was hovering around 90,000. Look at total leukocytic count. It is 4,200. But look at the differential. Here, lymphocyte count is on the lower side. So leukopenia with lymphopenia, with thrombocytopenia and anemia. ESR was elevated. It was 40 millimeter after first hour. Reticulocyte count, corrected reticulocyte count was also slightly elevated. Albumin was low, but CRP was elevated. Rest of the parameters in the metabolic profile were within normal limits. Now, in last case, some points were missed in history and examination. And in this case also, when after analyzing the baseline investigations, the physician went back and asked the child to open her mouth, there was ulcer visible over heart palate. And there was also facial puffiness with hair loss. So urine examination was done, which showed massive proteinuria. Protein creatinine ratio came to be 4. And RBCs were 4 per hyperfilled, and urine culture showed no growth. So to confirm the diagnosis, anti-nuclear antibody test was performed by indirect immunofluorescence on HEP2 cells, which showed typical nuclear homogeneous pattern with peripheral rim enhancement. This is a representative image showing homogeneous pattern. The nuclear material is homogeneously stained, followed by anti-dsDNA, which was significantly elevated, more than 1,000. Both the complements C3 and C4 were low, but the ANA immunoblot, where antibodies are tested against multiple nuclear antigens, all came to be negative, and anti-phospholipid antibody test was also negative. As this child had significant proteinuria, so renal biopsy was considered, which showed class 5 lupus nephritis, that is membranous nephropathy with full house effect on direct immunofluorescence. This is the latest Euler ACR classification, which was published in the year 2019. And as per this classification, the total score was 40. The cutoff is, as per this classification, is 10. So we reached our final diagnosis. This is a case of childhood lupus with mucocutaneous, musculoskeletal, hematological, and renal involvement in a 11-year-old girl. So coming to musculoskeletal involvement in SLE, arthritis or arthralgia can be present in 2/3 of the cases with childhood lupus. But here, the important point is that mostly these are symmetric polyarthritis and non-deforming and non-erosive. Mostly the arthritis go away with NSAIDs and corticosteroids within 6 to 8 weeks. Rarely they present with deformities and other sequelae. Myalgias and myositis can also be present in patients with lupus in 40% of the cases. So this was a study which was done to find out the predictors of arthritis in pediatric patients with lupus, and they did Cox proportional hazard ratio analysis, and in hazard ratio analysis they found that older age, male sex, RNP positivity, anemia, and thrombocytopenia were important risk factors for predicting arthritis in childhood lupus. So when to suspect lupus in a child with arthritis? Characteristic arthritis pattern, symmetric polyarthritis, non-erosive arthritis, mucocutaneous features which are present in more than 90% of the cases of lupus shouldn't be missed. Hematological abnormalities like anemia, often Coombs positive hemolytic anemia, leukopenia, lymphopenia, and thrombocytopenia. These are soft laboratory clues which shouldn't be missed. And last but not the least, constitutional symptoms like fever, like weight loss, like lethargy, and systemic features should be kept in mind. So to conclude, arthritis is not always rheumatologic, but arthritis in children has varied etiology, and arthritis can mask sinister underlying diseases. It's important to pick up the clinical and laboratory clues early that we have discussed. So arthritis can be rheumatological, can be malignancy, can be immunodeficiencies, can be coagulopathy, trauma, can be various infections, can be non-inflammatory arthropathy. So once again, thank you to IIP Karnataka, and over to sir.
Am I audible?
Yes, sir.
Yeah.
Yes, sir. Yes, sir. You're audible,
Yeah.
sir.
Yeah. So Archan, again, basically between the two of you, you have shown a complete spectrum of one child with oligo-GI, one child with IgA vasculitis, one child with lupus, and one child with leukemia. And realistically, about 24 years ago, when I made my transition into pediatric rheumatology, I started being reminded about my mother going into the kitchen with a sieve, what they call the chalni, and in that sieve, when you put the rice, or only the rice falls down and the stones stay upstairs. This is exactly what we do. That ideally we should be calling our branch musculoskeletal medicine. You get patients with true rheumatologic illnesses, which we keep behind to manage ourselves, and the rest, like the hemophilias, the mucopolysaccharidosis, the bony dysplasias, the deficiencies, etc., to be managed by somebody else. There are 2-3 points, if time may allow me, I could just stress upon. That is that while you are taking a history, please also take a history of psoriasis in the family. Okay, this is number one. Number two, considering that all of you practice in Karnataka, and I wanted to specify this point, especially because Sagar has chosen his calling at the most correct center there, for the simple reason that North Karnataka and south of Andhra Pradesh and south of Maharashtra is the consanguinity belt of India. So you will see a lot of children with arthritis and failure to thrive. Straight send them over for an immunology workup. Do not forget, somewhere along the way, being fooled by an inflammatory bowel disease, which may come to you in an older child with swollen joints and hardly have any manifestations related to the gut. But again, you may see anemia, fever, and a raised ESR and a low albumin. And when you see a low albumin with a normal urine examination, you start wondering, where is the albumin going? Check out liver function tests and think about inflammatory bowel disease. The last point, that when Archan started this case, somebody very quickly jumped to a diagnosis of systemic GIA, and I knew that they were walking into a trap. The simple reason was that Archan started by saying that the joint swellings were similar, symmetrical, started in the lower extremities. When you are looking at systemic GI, remember two joints, the wrist and the neck. These are almost always the first two joints to be involved. So I think with this, I am done with my comments, and I will leave it to the convener or coordinator to take the story forward.
Thank you so much, sir, for your words of wisdom. And there are a few questions. I think Sumita, madam, shall we go for the questions then?
Yes, yes, please. Yes, please. Yes, please.
So actually, it has been answered in the chat box, but for the benefit of everyone. So in IgA vasculitis, the rash keeps appearing. So what should we do for that? And should we do a urine examination each time?
Question for Sagar.
I think I answered it in the group that we periodically do urine examination for the first 6 months, as sir highlighted. It is not dependent on the rash. As a compulsory rule, we do it in everyone up to 6 months. And we really don't chase the rash. I tell the parents that don't worry about the rash. You can ask your child to wear full sleeve clothes. The rash is not going to bother the child. What will bother is the kidneys. So we have to monitor the urine.
Yeah, truly. I just tell them to wear longer pajamas so that they can't see the rash.
Thank you, sir. And in the discussion, there was a thing that why should we suspect scurvy in an autistic child?
Yes, very important. I too was very intrigued by this because the very first case I saw, and I said, this is strange. And we got an X-ray done, and in 15 minutes, there was every single feature of scurvy, which took me back to 46 years ago when I had finished my MD. And I thought that this was a disease which only Christopher Columbus must have seen on the ship. But what really transpired was that this kid was uniquely seen on a video consult during a sister hospital initiative with the Indonesian Pediatric Society. And they gave vitamin C, and in 7 days, the child started walking. So when we went back to check on what is the mechanism is that children with scurvy are very, very picky eaters. They are very choosy about what they eat. Now, some of them may just not like citrus fruits, sour foods, etc. And over a period of time, they develop vitamin C deficiency.
Thank you, sir. What percent of children with IgA vasculitis develop nephritis, and the question asked, and how to how to, I mean, monitoring of BP is also equally important. So usually what I mean
30
one
to 30 to 50% of children can develop nephritis, but the key there lies in the age. So we say any child who is age above 6 or 7 years is at a significant risk of developing nephritis, and it is very rare to see severe nephritis in a young child with IgA vasculitis. So if whenever we see adolescents with IgA vasculitis, we are really concerned, and this is one group we monitor very closely.
Thank you, sir. And
How common is Lyme's disease?
Lyme's disease.
Anybody has seen Lyme's disease in India? Sir, Kupchandani sir?
It's not very common in India. It's-
See, no, is it you're asking just because we spoke about limes and scurvy, or you're talking?
No, I didn't ask. There was a question there. I just read that one.
No, truly speaking, I have not seen a Lyme disease, nor have I had a reason to suspect it. Okay, because I believe that the vector does not reside here, and good luck to Donald Trump.
This question is asked by Neelang sir, not mine. Just I read it that one.
Yeah, yeah.
Neelang, hope you got the answer.
Yes.
So
I think we have come to
what
the
is
end
the
of the
picture?
question.
Yeah, Dr. Kishore Vaidya sir has asked, what is the picture of acute rheumatic fever and arthritis in present day practice? Uh,
Who would
Anybody?
take? Archan, would you
Yes,
take that,
yes, sir.
please?
Yes, acute rheumatic fever is typically migratory polyarthritis. So it is the point. Fever is very predominant, and it mainly involves the large joints, knee, ankle, and other features should also be taken into account, like carditis, like subcutaneous nodules, like chorea and erythema marginatum. So, and inflammatory parameters generally elevated, ESR, CRP, and the evidence of heart block may be found in ECG in the form of prolongation of PR interval, and evidence of antecedent streptococcal infections. So generally we do anti-streptolysin O, but remember that nowadays, because of vaccination coverage, because of antibiotic use, rheumatic fever, the incidence of rheumatic fever has gone down. It's very, very rare. So arthritis in children is not equal to ASO, and if ASO titer is found elevated in a child, don't prescribe injection benzathine penicillin or any other form of penicillin unless and until the child fulfills the criteria for acute rheumatic fever, which is modified Jones criteria.
I think sir wanted to ask whether it is prevalent, is what I understand.
No, that is my whole this thing, because during our postgraduate days and probably sir's time, every other fever with joint pains were rheumatic, unless otherwise proven. And we have seen a drastic fall of rheumatic fever and the arthritis, and we are thinking, I just wanted to bring about. Yeah.
I don't think we see rheumatic fever very commonly, sir. So I would be very, very skeptical to make any diagnosis of rheumatic fever. I'll keep revisiting my diagnosis, even if the ASO titer is high. And yes, sometimes it could be post-streptococcal reactive arthritis.
Yes.
That could be managed in a very different way, but I would be very skeptical making a diagnosis of rheumatic fever in today's world.
I
Thank you.
totally agree with both of you that it's much, much more often that we have to stop benzathine penicillin than
Yes.
start it. And whatever possibly Dr. Baindur, 40 years ago, when maybe you and I started sailing the uncharted seas, we may have called rheumatic fever then was possibly more out of our ignorance rather than, and like I have one slide which says that TB and rheumatic fever is not rheumatology. There is so much more to it, so much more. In fact,
Thank you, sir. Thank you. Thank you.
these two are a negligible part of our story.
There is one question. PSRA, please explain. Sagar, Archan, anybody? PSRA, please explain. Raju Khatke has asked the question.
That is what I mentioned, sir. So if you have a child with reactive arthritis and if the ASO titer is positive, you'd possibly think that streptococcal infection has triggered this, and you will treat it on the lines of reactive arthritis.
Okay. Sorry. Can IgA vasculitis life-threatening? Nandini has asked.
Yeah, if it has got renal involvement, we haven't seen that severe renal involvement. Occasionally, yes, if renal involvement is too severe, it can be life-threatening. And yes, we have seen sometimes very severe GI vasculitis that can become very troublesome. But fortunately, we have never lost any child to GI vasculitis. But we have resorted to higher immunosuppression when the GI vasculitis fails to respond to steroids.
Jalil, you have raised your question. Do you want to ask question?
Sir,
Jalil?
regarding, yes, sir. Thank you, sir. Regarding the second case, the lupus nephritis, I think it's sometime near to the pathognomonic. If you see an isolated palatal ulcer, which is a very prompt in diagnosing the lupus nephritis. That's what I know. The comment from the specialist, because this particular baby had ulcers.
Yes, sir. So palatal ulcer has very few differential diagnoses. So palatal ulcer is not lupus nephritis, but lupus. Palatal ulcer is a very suggestive sign of lupus, and it is the important thing is that it is painless. So in most of the cases, it is painless. So the child or the parents may or may not complain of these ulcers, but you should ask her to open the mouth and you should observe the hard palate, soft palate part to pick it up early so that the diagnosis and treatment can be initiated on time. And palatal ulcer is very suggestive of lupus.
Yes, sir. Thank you, sir.
So if I may interject, to answer the previous question, I have seen a child of IgA vasculitis with pulmonary hemorrhage. And I have seen one child way back, about maybe 9 or 10 years ago, of one child with neurological involvement, CNS involvement. But these are really true rarities and oddities, and we don't need to worry about them at all in day-to-day stuff. I think a very broad, crucial message that these 4 cases should give you is that I don't wish to sound derogatory, but the role of the primary pediatrician is to suspect these cases and refer them quickly. If you notice very subtly, Sagar and Archan did not touch upon the treatment aspects at all. Like somebody mentioned earlier, I think it was Sumita who mentioned that these patients require a long, sustained follow-up. Then triangulating care in concert with the specialist to whom you have referred this patient becomes very relevant. It doesn't mean you are losing the patient, but you are acting as a bridge between the pediatric rheumatologist and the family.
Thank you, sir. And one more question is, indication for renal biopsy in lupus. Is it mandatory for all BSLE diagnosed?
Dr. Archin has
Yes,
answered.
I have. Yes,
Yes.
I have mentioned. So, indications of renal biopsy in lupus when proteinuria is present more than 500 milligram per day, associated with hematuria, or more than 1 gram per day, or there is evidence of renal dysfunction in the form of azotemia. So, threshold for renal biopsy in lupus should be kept low, so that the renal involvement, the classification, the gradation, as per gradation, the renal involvement is diagnosed early and treatment is initiated. So proteinuria, hematuria, azotemia. These are the indications of renal biopsy.
Yes, I think there are no more questions in the chat box, and it was a great interactive session. And yes, one more last question has popped in. Dr. Mahesh Kumar has asked when to suspect autoinflammatory disorders.
For that, Sumita ma'am should arrange one more session.
Okay, we will do, Sagar. Don't worry.
Take it as a suggestion for the future
We will
show.
do.
Yeah.
Thank you. Thank you very much.
So meanwhile, we acknowledge the presence of Dr. Nitin Shah, Dr. Ganesh Kulkarni, and also Dr. Shivanand sir, everybody. Thank you all for joining here. Anybody, Nitin Shah sir, anybody, any question you want to ask? Any, any addition points to us? No, I think he's there. Okay. Fine.
Yeah.
Yeah.
So,
Sinchan, I think yeah.
Yeah. So we can actually, it was a great session, and the speakers were excellent in their presentations, and they brought out very important points for all the carry home messages for all the pediatricians. And the icing on the cake was the comments from the experts, both Deepti ma'am and Kupchandani sir, of course. And I